She'd been taking ibuprofen every day for almost 3 years. Not because she was reckless, not because she hadn't read the label. She took it because her knees hurt, and ibuprofen worked, and her doctor had told her years ago that it was fine for occasional use. So she took it. Every morning with breakfast, sometimes again in the afternoon. It became as routine as her blood pressure pill, just part of the daily handful. By the time she came to see me, her kidney function had dropped to about 55% of what it should have been for her age. She had no symptoms she could name, no pain in her back, no dramatic change in urination, nothing that had alarmed her or sent her to the doctor. She came in for a routine checkup. The blood work told the story her body had been quietly keeping to itself. What followed was one of the harder conversations I've had in my career. Not because the situation was irreversible, it wasn't, fortunately,
but because she looked at me and asked, very quietly, why no one had told her. She'd been seeing doctors regularly. She'd had blood work before, and somehow the connection between that daily ibuprofen and her kidneys had never once come up. I think about her often, because her story is not unusual. And what I'm going to tell you today is the conversation she deserved to have years earlier. Before I get to the specific medications, I want to spend a moment on the kidneys themselves, because I think most people significantly underestimate what these organs are doing for them every single day. Your kidneys filter your entire blood supply roughly 30 to 40 times every 24 hours. Every toxin, every metabolic byproduct, every excess mineral, every waste product your cells generate, it all gets routed through those two fist-sized organs sitting in your lower back. They decide what stays and what goes. They regulate your blood pressure. They manage your fluid balance. They signal your bones to maintain calcium levels. They tell your body to produce red blood cells. They do all of this silently, without complaint, without a single sensation to alert you that something is changing. And that silence is the danger. Unlike the heart, which sends pain signals when it's in trouble, unlike the lungs, which make breathing difficult when they're struggling, the kidneys give almost no warning as they decline. By the time symptoms appear, fatigue, swelling, changes in urination, confusion, function has often already dropped significantly, sometimes to half of normal, sometimes lower. This is why what happens to the kidneys in the years before symptoms appear matters so much, and why the medications that quietly accelerate that decline deserve a very direct, very honest conversation. The first medication I want to talk about is one you can buy without a prescription at any pharmacy, grocery store, or gas station in America. NSAIDs. Non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, aspirin in higher doses, and a long list of others you'd recognize by brand name. Advil, Motrin, Aleve. These medications are not inherently evil. They're genuinely effective for pain and inflammation. The problem is the gap between how they're marketed as safe, over-the-counter, everyday options and what they actually do inside the body at the doses and frequencies that many people use them. Here's what happens. The kidneys rely on a particular set of hormones called prostaglandins to regulate blood flow to the kidney tissue itself. Think of prostaglandins like a dial that keeps the kidney's internal circulation at the right pressure. NSAIDs block the production of those prostaglandins. In a young person with healthy kidneys and no other health issues, the kidney compensates relatively well. In someone over 60, particularly someone with any degree of pre-existing kidney decline, high blood pressure, diabetes, or heart disease, blocking that protective mechanism can meaningfully reduce blood flow to the kidneys and accelerate damage. Daily use is where this becomes genuinely dangerous. Not a pill after a hard day of gardening. Daily use over months and years, the way my patient was using it. And the particularly difficult thing about this is that pain is real. Arthritis is real. The need for relief doesn't disappear because the medication carries risks. What I encourage is a direct conversation with your doctor about alternatives. Acetaminophen taken properly, topical anti-inflammatory gels that have minimal systemic absorption, physical therapy approaches, occasionally prescription options with a different risk profile. The pain doesn't have to be left unmanaged. It just may need to be managed differently. The second medication surprises almost everyone when I bring it up. Proton pump inhibitors, the acid-reducing medications, omeprazole, esomeprazole, pantoprazole, Prilosec, Nexium, Protonix. These are among the most widely prescribed and widely purchased medications in the United States, and a significant number of people have been taking them continuously for years, sometimes decades, often started for a short-term reason that was long ago resolved. The kidney connection here is less direct than with NSAIDs, but it is real, and it has been documented in multiple large studies. Long-term proton pump inhibitor use is associated with an increased risk of chronic kidney disease and with a condition called acute interstitial nephritis, an inflammatory reaction in the kidney tissue that can cause sudden, significant drops in function. The mechanism involves how these medications interact with kidney cells over time and with their effect on magnesium absorption. The kidneys need adequate magnesium to function properly, and long-term PPI use depletes magnesium levels in ways that can quietly compromise kidney health. What troubles me most about this class of medications is the normalization of indefinite use. They were designed for short-term management of specific conditions, active ulcers, severe reflux, H. pylori treatment. They were not designed to be taken indefinitely without regular reassessment. And yet millions of people take them every day for years without anyone revisiting whether they still need them, what the lowest effective dose might be, or what non-pharmacological approaches might reduce their dependence. If you have been on a proton pump inhibitor for more than a year, please have an explicit conversation with your doctor about whether you still need it, whether the dose could be reduced, and whether your kidney function has been monitored during that time. The third medication on this list is one that gives me the most pause because it involves medications that people genuinely need for serious conditions, and I want to be very clear about how to hold this information correctly. Certain antibiotics, specifically a class called aminoglycosides, gentamicin is the most commonly known, and a class called fluoroquinolones, which includes ciprofloxacin and levofloxacin. Drugs prescribed routinely for urinary tract infections, respiratory infections, and various other bacterial conditions. Aminoglycosides are known to be directly toxic to kidney cells. Their use is carefully monitored in hospital settings, where kidney function is checked regularly during treatment. The problem arises when they're used in outpatient settings, in older adults, without adequate hydration or without monitoring kidney function before and after. Fluoroquinolones carry a different but real risk of interstitial nephritis, that inflammatory kidney reaction I mentioned earlier, in a subset of people, and the risk increases with age and with reduced baseline kidney function. I am not saying these medications should be avoided. Sometimes they're the right choice, and there is no reasonable alternative. What I am saying is that if you are prescribed any antibiotic, it is reasonable to ask, is this the most kidney-friendly option for my situation? Are there alternatives with a lower nephrotoxic risk given my age and my current kidney function? Has my kidney function been checked recently because it affects what dose is safe for me? That question will not offend a good doctor. It will earn their respect. The fourth medication category is one that many people in their 60s and 70s take regularly for a condition they don't always connect to their kidneys: contrast dye, used in imaging procedures. I realize this isn't a medication you take at home, but it is something administered medically with significant frequency. CT scans with contrast, cardiac catheterization procedures, certain types of angiography. The iodinated contrast agent used in these procedures is processed and excreted almost entirely by the kidneys, and in people with reduced kidney function, this process can trigger what's called contrast-induced nephropathy, a sudden, sometimes dramatic drop in kidney function in the days following the procedure. In healthy young kidneys, this risk is minimal. In someone over 60 with baseline kidney function that's already somewhat reduced, which describes a substantial portion of older Americans, the risk is meaningfully higher. The protection against this is straightforward: adequate hydration before and after the procedure, and an explicit conversation with the ordering physician about your current kidney function before any contrast study. If you have a scan scheduled and you haven't had your kidney function checked recently, ask for it to be checked first. It is a simple blood test, and it is information the radiologist and the ordering physician should have before administering contrast. This is the kind of thing that falls through the gaps in a fragmented healthcare system, where the cardiologist ordering the scan doesn't always have immediate access to the nephrologist's notes. You may need to be the one who connects those dots. The fifth medication category is the one most people are genuinely not expecting: certain herbal supplements and over-the-counter products. Aristolochic acid, found in some traditional herbal preparations, is one of the most potent kidney toxins known to medicine. Certain products containing it have been responsible for cases of rapid, irreversible kidney failure. But beyond that extreme, there are more common supplements that carry real kidney risk in people with reduced function. High-dose vitamin C supplementation, doses above 2,000 milligrams daily, can increase oxalate production, which in susceptible individuals leads to oxalate crystal deposits in the kidneys. Certain weight loss supplements, energy supplements, and detox products contain compounds that the kidneys must process in high concentrations, stressing tissue that may already be working harder than it should. Chromium picolinate, certain creatine products, excessive licorice root, and some traditional Chinese herbal preparations have all been documented in association with kidney injury. The word natural does not mean safe, and the fact that something is sold without a prescription does not mean the kidneys process it without consequence. If you take any supplements regularly, even ones that seem benign, your doctor should know. Not because most of them are dangerous. Because the ones that are dangerous are genuinely dangerous, and the interaction between supplements, medications, and reduced kidney function in older adults is something that needs to be considered as a whole picture, not in separate compartments. Let me bring all of this together now, because information is only useful when it leads somewhere. Get your kidney function checked. If you haven't had a creatinine and eGFR in the past year, ask for it at your next appointment. It is a standard part of a comprehensive metabolic panel and costs almost nothing. Your eGFR, estimated glomerular filtration rate, is the number that tells you what percentage of normal kidney function you currently have. Above 90 is considered normal. Between 60 and 89 suggests mild reduction that warrants monitoring. Below 60 warrants a more detailed conversation and potentially a referral to nephrology. Knowing your number matters. It changes how risk-tolerant you should be about the medications and supplements you use. It changes what imaging procedures require extra precautions. It changes what doses of certain medications are safe for you. Hydration is genuinely important for kidney health in a way that's underestimated. The kidneys work in solution. When you're mildly dehydrated, which older adults often are, partly because the thirst mechanism becomes less reliable with age, the kidneys concentrate their work into less fluid, which increases the burden on the tissue. 6 to 8 glasses of water daily isn't just a cliche. For kidney health specifically, it's a real target with a real rationale. And have an honest conversation with whoever manages your medications about the full list of what you're taking. Every prescription, every over-the-counter medication you use more than occasionally, every supplement. Ask specifically, given my current kidney function, is there anything on this list that deserves a second look? That conversation, had once and revisited periodically, is one of the most protective things you can do. There's something I want to say that goes beyond the clinical. We live in a medical culture that is very good at treating acute problems and less good at protecting what's working. The system is designed to respond to crises. It is not always designed to prevent the slow, quiet erosion of organ function that happens over years of accumulated exposure to things that seemed harmless. That protection, that proactive attention to what is still working, largely falls to you. Not because your doctors don't care, but because they're seeing you for 15 minutes every few months and can only work with what they know and what you tell them. You are the constant in your own healthcare. You are the one who knows how long you've been taking that ibuprofen, how many years you've been on that acid reducer, what supplements you added last winter. That knowledge, brought clearly and specifically into the medical conversation, is genuinely powerful. It closes gaps that the system leaves open. It gives your doctor information they need, but may not think to ask for. My patient, the woman I told you about at the beginning, she did the work to understand what had happened, to change her pain management approach, and to monitor her kidneys carefully going forward. Her function stabilized. It didn't reverse entirely, but it stopped declining at the rate it had been. She protected what remained. That's what awareness makes possible. Not fear, not paralysis, just protection. Tell me in the comments, did any of these medications surprise you? Have you been on a long-term NSAID or a proton pump inhibitor without anyone raising the kidney question? Are you someone who takes supplements alongside your prescriptions and has never had that full picture conversation with your doctor? I want to know, and I want others who are watching to know that they're not alone in navigating this. If someone in your life takes a lot of medications or supplements and has never had their kidney function checked recently, share this with them. It might be the most practical thing you do for them today. There's another video I'd point you toward about the early warning signs of kidney stress that show up long before any blood work looks abnormal. Small things most people miss. It follows directly from today's conversation and fills in a piece of the picture that I think a lot of people need. Take care of yourself, and the next time you reach for that bottle in the medicine cabinet, whatever is in it, know that it is worth asking one simple question. What is this doing to my kidneys?